This is Mary Jo Dales reporting from the 7th Annual Community Oncology Conference in Las Vegas, Nevada, where we talked with Dr. J. Randolph Hecht about the future of targeted therapies for colorectal cancer.
There's a lot of work that's being done right now. Perhaps the most important things are actually cooperation between patients, surgeons, clinicians, and researchers, because there's nothing that really substitutes for getting the tissue. And if you don't have the tissue, and it's hard to believe, but there are trials that have been done in the last 5 years without mandated tissue collection. So these large, well-annotated banks of tissue really are critical in trying to retrospectively go back and identify targets. Now, the pharmaceutical industry has been synthesizing all sorts of different inhibitors. The question is trying to be able to determine which of those inhibitors should go into patients, and not just go into patients in an unselected way, but should go, in a selected group of patients so that you don't get a negative trial. That's a lot of the translational work. That's called translational oncology, and that's the translational work that we do at UCLA.
And tissue collection, the process, some of the challenges to try and get that?
HIPAA has really been the biggest problem. I'm old enough to remember when I could go to the tumor registry and say, give me all the cancer patients, colon cancer patients' names who have had colon cancer in the last 10 years. Okay, and then I would go to the pathology department and say, please give me those tumor blocks. Can't do that anymore. And in fact, it's been difficult even with trials that have been done now. For example, there's a trial that I ran, which we published with panitumumab, an anti-EGFR antibody. And in the consent specifically, they were talking about looking at things in the EGFR pathway. So the question is that someone then had a bright idea and said, maybe we can look at other things. And the question is, can we use the samples, even though it's really for the same idea, without having to reconsent the patients? And the problem with cancer patients, particularly people with metastatic disease, is they may not be around to be reconsented. So things that are putatively for the protection of patients may actually be inhibiting research.